gentlemen. In any event, today we're going to learn a little bit more about something that's popping up in the news a lot lately. If you watched Good Morning America this morning and a couple of other news shows last week, we talked a lot about chronic traumatic encephalopathy. That is damage to your brain caused by trauma. And people, we know that head trauma is a risk factor for developing Alzheimer's or another kind of dementia. So it's not only athletes who can suffer from develop this type of dementia, but people who are victims of domestic violence, military personnel who have suffered injuries during their military service. Yes, football players, but soccer players, anybody whose head is injured and is at risk of developing a concussion as a result of their participation in that particular sport or other activity. With us today is Dr. Michael Alosco, who's a neuropsychologist from Boston University. His area of research is to focus on those risk factors that are associated with neurodegenerative conditions such as Alzheimer's and chronic traumatic encephalopathy. He's particularly interested in the contribution of cerebrovascular disease to the development of Alzheimer's and related dementias. So one of the things we've talked about previously is that certain aspects of dementia can be prevented. And we've learned that greater exercise is something that's helpful, greater socialization is important, but also avoiding things like head injuries. So today, Dr. Alosco is going to inform us more about this particular topic and let us know where we might be able to get involved. We don't have a head trauma study going on here in Georgia, but maybe there's something that we can join remotely. So Dr. Alosco, the floor is yours.
Thank you so much, Dr. Parker, and I'm very excited to be here, and I'm going to try to match John's energy. That was so awesome. And so, yes, I am going to talk to you all today about chronic traumatic encephalopathy. It's something that's I'm very passionate about, and that's something I've been researching now for 10 or more years. I will refer to it as CTE throughout the talk. And really my goal here is to make this really applicable to everyone, to better understand, what are the risk factors for this disease, but also where do we stand with being able to help patients out in the community. So just a little bit of a roadmap for today. So I'm going to start off with some of the basics in CTE. So what is CTE, and what causes it, or what is its risk factors? I'm going to talk about where do we stand with being able to accurately detect and diagnose this disease in people while they're still alive. And this is really important because we need to be able to accurately diagnose something in order for us to understand how we can treat, and in this case, perhaps even prevent the disease to begin with. And then I'm going to talk about action steps for optimal brain health. Again, what can we do as both providers, but also as patients in terms of taking steps to help deal with conditions like this, but also more broadly in terms of progressive brain diseases that are similar to CTE. Okay, so the research we focus here on at Boston University is really on the long-term effects of what we call repetitive head impacts. And this term is very easy to kind of visualize if you think about the sport American football. It's just it's exactly what it sounds like. It's impacts to the head. And I'm going to break this down a little bit in a second. And right now, a lot of our research is focusing on developing ways we can diagnose CTE in addition to other forms of dementias like Alzheimer's disease during life. So CTE has actually been around for quite a long time, despite it kind of more recently popping up in the news. It's just been called different things. So we can actually date it back to the 1920s when it was actually called something called punch drunk. And it was mostly described in fighters or boxers. Another term it's been commonly seen is dementia pugilistica. It wasn't really until 2008 or so, or five, I should say, when it was first, the changes we see in CT in the brain were first found in American football. And that's really when it became more mainstream in society, and there's a lot of awareness to it. So what is CTE exactly? So I think it's really important to understand that right now CTE is a neuropathological diagnosis. That means that we can only currently diagnose CTE after someone passes away and we look at their tissue under a microscope. And that's what I'm showing you here. So this is actually, we have a brain bank here at BU. It's actually the largest in the world of CTE tissue. We have over 1,400 people who donate their brains for research. And this is an example of some of the tissue we've looked at. And this is actually showing you what CTE looks like under the microscope. So in our brains, we all have this protein called tau. It's very important for healthy brain function. But what happens in CTE and also Alzheimer's disease is that this tau becomes abnormal. In CTE, and this tau, the abnormal tau you can see here in brown. And in CTE, this abnormal tau tends to gather around small blood vessels. So this white circle here is actually a blood vessel. Also in CTE, the tau tends to gather at the bottom of the folds of the brain. So we all have these folds in the brain. And this is specifically where we see that abnormal tau tend to gather. So this pattern that I'm describing right here is different from Alzheimer's disease. While Alzheimer's disease, you can also see abnormal tau. This is quite unique to CTE here. Also, if you look here on the left, where the tau starts to gather in the brain is also different. So for example, and the next slide illustrates this. If you look at CTE and Alzheimer's disease next to each other, the tau in CTE really starts to begin in the front parts of the brain, as you see here. And then it starts to go to the side parts of the brain, starts to reach the middle parts of the brain or the memory centers, the hippocampus in later stages. And then in the final stage, which is stage 4, it really becomes widespread. But if you look at Alzheimer's disease, that pattern is different, right? In Alzheimer's disease, it starts more in the middle part of the brain and then progresses up into the front parts and the back parts later on. So the type of tau and where it starts to gather are different in CTE compared to Alzheimer's disease. When I think about CTE, I like to think about it in this framework. It's somewhat simplistic, but I think it kind of drives the point home. So in CTE, the primary risk factor for it is repetitive head impacts. And I'm going to define that in just a second. But we've almost always found CTE in people who've had this history of repetitive head impacts, not in people who do not have it. So we think that this must be present for this to develop, and that this tau that I just described to you causes problems with thinking and memory. But it's really not, there's really much more to the story, because not everyone who has these impacts are going to develop CTE. There's other risk factors at play that we're studying, things like age, things like genetics, things like the type of impacts that someone experiences, factors of socioeconomic status, and so on. And we're studying all these different types of risk factors. And we also see that these repetitive head impacts can also drive other types of problems with the brain that may actually contribute to these thinking and memory symptoms. So what are repetitive head impacts? So repetitive head impacts is any type of force that's applied to the head, okay? And regardless of whether or not that results in what we commonly know as traumatic brain injury, okay? It's just a force being applied to the head. Now, that force can result in brain injury, which can then lead to symptoms. And that's commonly what we think of as our concussion or traumatic brain injury. But what we're particularly concerned about are impacts to the head that don't result in symptoms right away, but they are causing some type of injury to the brain. And we think about these as non-concussions, or subconcussions is another term used. And if you think about the sport American football, you think about the number of times people hit their heads, every down, every play, every practice, every game. That's a lot of impacts. Maybe those impacts aren't resulting in symptoms, but are causing injury. Some of them might be causing symptoms. But that's what we're really concerned about. And I want to drive the point home that we're not talking about one concussion, one traumatic brain injury, 2 or 3 or 4. We're talking about thousands of these hits to the head over someone's lifespan. Because that's really important, because I think one piece of information that gets confused is that people get concerned that they have this potentially progressive brain disease because they just hit their head and now they have a concussion. But no, we don't see that. Concussion, a majority of people recover from a concussion in 2 weeks or so. Sometimes they have longer symptoms and it takes a little bit longer, but we don't see a link between concussion and this disease. So I just want to present some interesting data that drives that point home. So this was actually this was a study done a little bit a while ago now, in 2015. It was led by Dr. Dixon out of the Mayo Clinic Neurodegenerative Disease Brain Bank. And they took their brain bank, and it consisted of individuals who have different types of progressive brain diseases. But they don't have a focus there on CTE or repetitive head impacts. But they wanted to go through their brain bank of individuals and see who had a history of people who played contact sports. And so what they did was they took their just over 1,700 men and reviewed for evidence of history of TBI or participation in sports. And then they looked at the brain for CTE. And then they also took a control group. So these are, age and disease matched men and women who didn't have any contact sport history or other types of exposures. And the take-home message of this is that CTE was only detected in individuals who had a documented participation in contact sports. So they did not find CTE in the 198 individuals who had no history of contact sports, including those who just had that single TBI. So again, it's really driving the point home that it's this exposure to contact sports and the repeated hits to the head over the course of someone's lifetime that seems to be one of the greatest factors for CTE pathology. And more recently, in this study led by one of my colleagues here at BU, we wanted to delve a little bit deeper into the relationship between playing American football and CTE. And this is exactly what this study did here. And so this included, we took our brain bank here at BU. This is a brain bank of football. This is just football players for this study. And so there's about 266 of them. And again, they were all men. And we're going to get into the limitations of why we study football players and particularly being kind of all male population. About 17% of these individuals were identified as being Black. And they were around 61 years of age. And you can see that most of these people played professional or college, but you had some people who also played just at the high school level in terms of football. And what the study found was a dose-response relationship between the number of years of football played and risk for CTE. So again, in this sample of people from the brain bank who played football, the odds of CTE increased by 30% for each year of football played. And we also found that among those with CTE, those who played more football also had more severe disease. And what was a really interesting point about this study is the way that they handled selection, or who's coming into our brain bank. So people who agree to donate their brain are different from the regular population for that very fact. And also people who donate their brain to our center tend to be more likely to have symptoms and might be more likely to have CTE. And the point that this paper made through kind of sophisticated analysis was that these relationships held even after we accounted for what we call selection bias, or factors that, that might bias the results because of who's coming to us. We also find it in other types of settings. So it's not just American football. We do know most about American football. And the reason we've studied that sport is because of the homogeneity it offers in terms of exposure to repetitive head impacts. It provides a good model for research. But of course, there's other sports. There's soccer, there's rugby, like Dr. Parker said, intimate partner violence. These are all other sources of repetitive head impacts that are being studied for their long-term consequences on the brain. And these are just some examples of CTE being found in for example, soccer players and then also rugby players. So some important points about risk for CTE. Like I mentioned at the beginning, it's nearly exclusively described in the setting of repetitive head trauma. In particularly, mostly elite contact sport athletes. And I want to emphasize elite, because when the people that come to our brain bank and where we find CTE, we do find it in amateur level players, and we do find CTE at higher rates. But there's actually studies now out there where they look for CTE in more of a community or a general general population autopsy samples, and they find very low rates of CTE. And I think what that tells us is that this disease might be more common in people who play at very high levels, for example, American football. But people who are just playing at the high school level, which is most of the population, perhaps are at much lower risk. And I think that's important information. So current challenges. So as I mentioned at the beginning, CTE can only really be diagnosed after death through examination of brain tissue. And we need to be able to figure out how to accurately detect and diagnose this disease during life so we can start to figure out how to prevent and treat this disease. And so we have made a lot of progress. So back in, this was about 2021, this was published criteria. So there's something called TES, or traumatic encephalopathy syndrome. Another acronym for you. But TES is intended to reflect the clinical syndrome of CTE. So it's intended to reflect the signs and symptoms of CTE. And these were originally developed back in 2014. Those 2014 criteria were found to not be so great. So we convened, and with working in our collaborators with NIH and NINDS, we convened a consensus panel, and we came up with revised criteria. And I'll go through these for a little bit, but I won't go through them through each point. But so the primary features are that someone must have substantial exposure to repetitive head impacts. So football, other contact sports, military, etc. There must be the presence of impairment in thinking and memory, particularly in episodic memory, so trouble remembering recent events or information, executive function, so multitasking, problem solving, planning, or organization. There could also be neurobehavioral dysregulation. So this is a term used to refer to trouble with managing emotions, getting angry quickly, being impulsive. I will say that while we see cognitive impairment as a frequent consequence of neurodegenerative disease, including CTE, this neurobehavioral dysregulation has been quite hard to understand. In particular, I say that because we're not sure if it's specifically related to the tau of CTE. There's some evidence to support that it might be, but it also could be that maybe people who go into these sports like football are more aggressive to begin with, and this aggression gets worse with age or gets worse with head trauma. Or maybe it's related to other things from the repeated head trauma that's not tau related. But either way, that's a symptom we see a lot in the setting. We're just trying to understand what exactly is causing it. And then there's some other supportive features as part of the criteria, whether or not someone's having trouble with their daily function, cooking, cleaning, driving, those types of things. But I want to emphasize that these are not ready for use in the clinic. These are really to facilitate research. They're research diagnostic criteria. They're not ready for use in the clinic because we don't know how well they work yet. We're still learning what the specific signs and symptoms of CTE are. But I will say that our knowledge of these criteria are growing, and they're specifically growing through neuropsychological studies. And so these are some references that will be available on the slide, but I do want to go through one from our group here recently, this past year actually. So neuropsychological evaluations are one of the cornerstones for being able to diagnose neurodegenerative diseases, right? So neuropsychological evaluation, we do it for a few reasons. So one is, as we get older, we all lose memory. It's part of aging. But a neuropsychological evaluation will allow us to answer the question is, does this person in front of me, who say they're 60, do they have more problems than I would expect for a 60-year-old? Is it abnormal? And that's what a neuropsychological evaluation can tell us. Neuropsychological evaluation can tell us, is the impairment in thinking and memory, how severe are they? Are they starting to interfere with someone's ability to function? And then different diseases, different disorders, they can produce different patterns or profiles. And therefore, we can look at these patterns and profiles and start to get some insight into what might be causing this person's thinking and memory problems. And so that's why it's really important to nail down the patterns associated with these different progressive brain diseases. And that's what we sought to do recently. So this is a project, it's known as the Diagnosing CTE Research Project. I'm not going to get into all of this, but briefly what it included was 240 participants. 120 of these included former National Football League players. 60 included former college football players. And then we had a control group of 60 individuals who had no source of repetitive head impacts and asymptomatic. All of these individuals, the study actually just ended this past November, but all of these individuals completed a 2-day evaluation, including really detailed neuropsychological testing. And so for this study, the sample, after we accounted for missing data and some other reasons, we had 170 former football players. They're about 58 years old. About 33% of them reported being Black or African American, and they were highly educated by as well. And you can see that 111 of them were professional football, and then about 59 were not. And really, the primary take home from this study was that the most common impairment we saw was for memory. And so in particular, we found impairment for remembering a list of words. About 45% had an impairment on that test. We look at that test really closely with things like Alzheimer's disease, and now we also see it in people that at risk for CTE. We also found about 15% were impaired executive function. I was a little bit surprised there. I thought that might be a little bit higher given some of the kind of more impulsivity we see in this population. It could be related to our tests, but either way, I was a little bit surprised there. And then we found some scattered impairments across other tests. So this pattern, though, this pattern in impairments in memory, that is very similar to Alzheimer's disease. And so as clinicians trying to come up with accurate diagnosis, this actually makes it very challenging to differentiate, potentially differentiate CTE from Alzheimer's disease. So how are we going to do that? One approach is through biomarkers. So we all know what a biomarker is. If you have trouble with your heart, you get an EKG. Diabetes, you look at blood levels. It's a measure of biological function. Same concept, but we're talking about the brain here. Can we get a measure of brain function? And this is in Alzheimer's disease and related types of dementias. The best approach is you sit in front of the patient, you take their history, you do the neuropsychological testing, you do a neurological exam. All of those are designed to characterize that person's signs and symptoms. You combine that with a biomarker, and that's going to get you etiology, or the cause of the signs and symptoms. So that's the best approach to really coming up with accurate diagnosis, and that's the framework we're taking with CTE. And how do we do that? What are the biomarkers we're using? So very similar to Alzheimer's disease, right? So here's a picture of your neuron. So in Alzheimer's disease, we're very much interested in amyloid and tau, right, in detecting those proteins. So in the amyloid in Alzheimer's tends to occur outside of the cells, and they form plaques right here. So in a healthy person, these can be cleared, and you don't get these plaques. But these aren't cleared, and they become harmful in our Alzheimer's disease. And actually, they start to gather years and years before people have symptoms. Then there's also the tau, which tends to gather inside of the cells. And we actually think that's what's causing the cells to die and then leading to the thinking and memory problems. So we don't see this amyloid as a consistent feature in CT. So that's one way to help us differentiate AD and CT. But we're trying to figure out how we can detect this protein tau. And so we can do that through imaging of the brain. We can do that through sampling of fluids. So let me give you an example of an amyloid PET scan. This is what it looks like. You may have heard of this before. So a PET scan, it's an imaging technique. What it involves is someone gets a tracer injected into their forearm. It is a radioactive tracer. But these tracers are designed to go up into the brain, find a certain protein, stick to it, and then you can take pictures of it. Okay? And then you can visualize it like you can here. So in this case, you get a tracer that's designed to stick to amyloid protein. And what you're looking for when you read these is being able to tell the difference between gray and white matter. We all have gray and white matter in the brain. And when we can tell that difference, that means that it's a negative scan. When it's positive, essentially the tracer is sticking to a bunch of amyloid in the brain. It's everywhere, and then you can't really tell the difference between gray and white matter. So in this scan, if you kind of clearly look through it, you can see the dark part, the gray, you can see the white matter. So this is an example of a negative scan. I thought it didn't make it onto my slide, but I had an example of positive scan. But essentially what you would see is that this whole scan would just be dark. You wouldn't see that gray matter. And that's because there's amyloid there, and the tracer is being taken up into the gray matter of the brain. We're also doing studies in CT. And so just one quick point again on here is we just published a paper where we find really low rates of positivity on this scan. So again, as part of the process in evaluating our workup for potential concern for CTE, this helps us to rule out Alzheimer's disease, because these are FDA approved for Alzheimer's disease. We're also looking at tau PET, so same concept as amyloid PET, but now we're talking about tracers that can detect the tau in the brain. So there's tracers out there that work quite well for Alzheimer's disease, and we're trying to apply that to a sample of people at risk for CT to see if they work. So can this tracer detect that tau that I showed you, that's shown here in CTE? And this is a study we're working on in collaboration with UCSF, where we're recruiting people at risk for CT and seeing how well a certain tracer works. It's still in process, so I don't have the findings to present yet, but we're seeing in general kind of inconsistent findings with these tracers and kind of small effects, but we still think that they might have usefulness. But in the end, these are really meant to be optimized for Alzheimer's disease. We're also looking at the blood. So this is a very hot topic in Alzheimer's disease, blood biomarkers. Can we take blood, sample it for the proteins of Alzheimer's disease, and come up with an accurate diagnosis? We did this paper down below and published in Brain, where we found that looking at certain p-tau in the blood was quite good at predicting Alzheimer's disease pathology after death. We're trying to do the same types of studies in CT as well. We're also looking at magnetic resonance imaging. So MRI is also should be a very kind of integral component of evaluating neurodegenerative diseases. And this is why. So these neurodegenerative diseases, they cause cell death, they can cause shrinkage of the brain, or the technical term is atrophy, okay? And that tells us, is there essentially death in the brain going on, or cells dying? And different diseases produce different patterns of shrinkage, and those patterns can, again, provide insight into what might be causing it. So if you look here at this figure, we can detect atrophy by looking for space. So on the right here is a healthy brain. On the left is someone with a lot of atrophy. And I can tell there's atrophy because if you look at the folds of the brain, there's a lot of space. Here, you don't get that space. You can also tell because these are someone's ventricles. When there's shrinkage, these ventricles tend to get big. Everyone has these. They're filled with fluid. The fluid is meant to bathe the brain, protect it, clear waste. But these get bigger when there's shrinkage. So these are big. These aren't as big. You can also look down here. These are the memory centers of the brain, or the hippocampus. And again, you can see space. Whereas over here, there's not space. They're nice and plump and kind of filling it together. So that's what we're looking for. And we've done a study in CTE. These are people where we had their MRIs during life. They donated their brain, and we were able to confirm whether or not CTE was present. And we compared, we had neuroradiologists rate them for atrophy, and we compared it to a group of people who had no problems with thinking and memory. We found more atrophy or shrinkage in the front parts of the brain, the side or the temporal lobe atrophies, the memory centers or the hippocampus. And then we also found higher rates of what we call a cavum septum pellucidum. So what that is what you see here, a tear in the tissue that separates these ventricles. So you can see here a nice single piece of tissue. You see a tear here. Now, this can happen at birth. This can happen in people in the general population have it. So it's not specific, but we do tend to see higher rates in people who've had head trauma. We don't think it necessarily correlates or predicts symptoms, but maybe it's a marker for wider spread neurodegenerative disease or brain problems. We also look at something called a flare scan. So this is another sequence, and it's visualized up top. We look at, is there injury to the white matter, right? And as we get older, to some extent, we all develop these bright spots. It's part of aging. There's just a continuum. Some people who have more problems with the heart tend to have more of these lesions in the brain. They can be a driver of thinking and memory problems, and I'm really interested into seeing, do repetitive head impacts lead to some of these lesions that might explain some of these symptoms? And so we did this in a study from that same sample from the Diagnosing CTE research project. This was a very similar sample from the neuropsych paper I presented to you before. And what we found was that the American football players did in fact have more of these lesions compared to the control group, particularly in those people who were older. And we particularly found them more in the front parts, the side parts, and kind of the side parts of the brain. We didn't find it in people who were in the younger age groups, though. So if I had to summarize where we stand right now with CT, the neuropathology is really increasingly well defined. We have a good understanding of what it looks like under a microscope. We think repetitive head impacts are necessary, but not sufficient for CT. We're trying to clarify the specific signs and symptoms as well as the biomarkers. We need to better understand generalizability. How does this look in females? We need to look at other sources, and we need to get a hold on how common is this. But the research is making an impact, and this is a recent statement updated by the NIH, where CTE is caused in part by repetitive traumatic brain injuries. There's been some debate about whether or not we think repetitive traumatic brain injuries or head impacts is causal or necessary, and I think this explains all the evidence that has supported that statement.
So, Dr. Alosco,
Yeah. Yes.
couple of questions. You said that we're not really sure what some of the symptoms are. And lots of us watched football on Sunday. And a lot of people, there are a lot of football players out there. So at what point in time should somebody who's a professional rugby player, football player, start to be concerned about this? I mean, we see fights on the sidelines around the field. I mean, should we say, oh my goodness, they're showing signs of CTE? I
Right.
mean, how are we supposed to address this? And, in our talks, we tell people, young children shouldn't participate in contact sports before
Right.
13 or 14.
Right.
What is going on in the National Football League, and how are we advising parents and grandparents with respect to should my kid play football or not?
Yeah, so a lot of points there. So the first point is I would say that the National Football League has made efforts to reduce head impacts and have done increasingly better job with detecting and managing concussion as well. For some examples are, they've made certain rules change to reduce head impacts. They're trying to encourage different techniques as well, tackling techniques. There's a difference between an active player who has symptoms and someone who's older and has symptoms. In CTE, we do tend to see that the symptoms tend to start later on. So could be quite a while after they stop playing. In those people, I would recommend that if you start to notice changes in your memory, mood, or behavior, I would seek out care. And I say that because regardless of what's causing it, we still need to understand what's going on, how severe it is, and there might be factors going on that we can potentially treat and help improve. So, for example, if there's depression, we know how we can potentially treat that. If there's trouble with sleep, we can treat that. So that's my number one recommendation. In terms of your other questions about, youth tackle football, I would agree that I think, there's a lot of advocacy efforts now to encourage flag football and to delay tackle until high school. And I'm also in agreement with that. I think that we have to think about whether or not it makes sense to have this repeated hits to the head during times of really peak brain development. And I think, and another, you mentioned it before too, even the banning of heading in soccer has been a positive step forward too, below a certain age.
Okay. Okay, so while I'm enjoying watching football on Sunday, as most people who like football do, should we be worried about those football players?
Yeah, yes, right. So I'm sorry, I missed that point. It's hard, right? They worried in the sense that, they are engaging in something that might be increasing risk for a later neurological problem. But it's really hard to say at that specific time. I think there's a lot of risk for concussion that can cause symptoms. And really, the specific signs and symptoms they're showing in that time, it's really hard to say or pin that on CTE or other things at this time. It's just too difficult to say by in that manner.
Okay, I got off of this, but I'll let you go on. Finish. But I wanted to know about those symptoms, and you said research is ongoing, but irritability and personality changes were things that were.
Yeah, I mean, more broadly speaking, right? Those symptoms, and I say because a lot of these symptoms, they can happen in a lot of other conditions, like even memory as well. You see in Alzheimer's disease, so they can happen in a lot of other situations, and we're just trying to kind of nail down, what are the specific signs and symptoms of CTE. When you're talking about active players, and then the setting of concussion and hitting their head, there's a lot of different reasons why those symptoms can arise.
Okay, all right.
Yeah, and I mean, to that point, I mean, I don't have much left to say. I think, I like to talk about how not everyone who has these head impacts will develop later life problems, and that there are treatable causes for some of these symptoms, and we need to focus on that. And we do that. One model we have is a memory and aging clinic, where we here, at least at BU, we have this specialty clinic focused on Alzheimer's disease, other types of dementia that's multidisciplinary, involves neurology, neuropsychology, and we get psychiatry involved if needed as well. It's closely integrated with our research. But we really focus on education. So a lot of the things you're asking, Dr. Parker, are common questions that people have. I've had 2 or 3 concussions. Do I have CTE? What I have these symptoms. Is this from CTE? And we always tell everyone, we can't yet say right now that you have this disease, but we can talk about what we can do and help treat the things we know how to treat. We talk about getting them into talk therapy, cognition. There's a lot of behavioral things you can do to manage it. There's also, if Alzheimer's disease is present, there's some medications and more recently FDA approval of drugs to consider. And then we kind of check for reversible causes, checking people's vitamin B12, thyroid function. We get them involved in sleep workup if they need it, occupational therapy. We address things at home, safety concerns. We talk to the caregivers, come up with care plans. And that's it. And I went through the last part a little bit quick, but thank you again for having me. It's great to speak to you all, and happy to take any questions.
Okay, there are a couple of questions, and I will read the ones that I've gotten, but I've kind of got to some of them. You answered them live, but I wanted to get to the symptom one. But there are a couple of questions that say, is CT exacerbated by or made worse by things like diet, alcohol, and sleep? And you kind of alluded to that.
Yeah, I mean, all of those things, regardless of the cause, are going to make things worse if they're not in check. So I would say the same principles apply for those things in general healthy aging as they do here. If you have a poor diet, not exercising, we know that can be harmful, and all the positive benefits. So yes.
Okay. There's a question in the chat. Is there a link between CTE and substance abuse?
Yeah, that's a great question. We see substance abuse quite a bit, and we don't necessarily think that substance abuse is going to lead to this CTE, right? But we do think that if people have substance abuse, that these can certainly be contributory to some of the symptoms we see. It's a little bit hard to understand, right? Just like in other settings, if there's a neurodegenerative disease and substance abuse is present, are they kind of feeding off of each other? I think we're still trying to understand that, but it's a good question.
Another question. On your slide, maybe 2 minutes ago, you said that at Boston University, you can come in and get a 1-day consultation evaluation for CTE. Is that via a research study, or is that an actual diagnostic study? And how do you get in touch? What's the number we call?
Sure. So, yes, we have a clinic and a research center. They are closely integrated. Some people are just part of the clinic who need care. Others people just do the research. I'm putting in the chat right now. You can contact me directly, and I will get you to the right place, depending on what the needs might be. But yes, we provide care for diagnosis, treatment planning, and then we also have various research opportunities as well.
Is there anything that might be a virtual option for people who live in this area to participate? Or are there people who are doing research in CTE here in Atlanta? Maybe not at Emory.
Yeah, so there is, I just put a link in there. It's hits.org. If you played football or soccer, we are doing a fully online study, remote study to monitor people who played football and soccer over time. It's a bunch of online tests of thinking, memory, and mood. It's interfaced with the Brain Health Registry out of UCSF. And we're also getting a new study on its way, hopefully launched in early 24, where it'll involve that study I just linked, plus a blood draw in our efforts to develop blood biomarkers for CTE. In Emory or Atlanta, I am not off the top of my head familiar with what's going on. I know it's not Atlanta, but in Florida that we have collaborators. But let me look into it and I can get back. But I'm off the top of my head, I can't think of my.
Okay, but this hits.org is something we can access that might give us access to an online study for people with previous head injury. So
Correct.
Dr. Alosco has put that in the chat. If you know if you or somebody you know has had a history of head injury and maybe played football, maybe not NFL football, but repeated head injuries, this may be an online study for them to participate in to better inform about the topic. There is a question from Dr. Culp. You talked about cholinesterase inhibitors, and as a primary care doctor, we use those for managing people with Alzheimer's. But if you know somebody has had repetitive head injuries and they're having some cognitive and behavioral changes, are those medicines really for you? Is Aricept, Exelon, are those medications for them? I see a lot of antidepressants, but I mean, should
Yeah.
they be on cholinesterase inhibitors?
Right, and I'll caveat that with, I'm not an MD, so the medications aren't in my wheelhouse, but I'll say that I specifically talk about it in the setting of AD, right? Because it's not just AD, we treat AD too. I would say that we don't know if these are work or safe even, or indicated in the setting of people at risk for CTE. It is a judgment call, I would say, but there's no kind of indication yet for specifically CTE.
Okay, I think I've exhausted all of the questions that are online and in the Q&A. Thank you so much, Dr. Alosco, for joining us today. We will have this up and available within the week on our YouTube channel. And I want to stress again that there is an online opportunity for us, and that's HITTS.org for looking out for people who may be interested in research at this distance if we don't live in Boston. So thank you, Dr. Alosco. This has been most informative, and hopefully you'll have something else to tell us about next year.
Yes, thank you for having me. I really enjoyed it.